actually Marlene's been really instrumental in driving these seminar series for Griffith. Lots of behind the scenes work. Love our logo and everything that we've had developed for that. So thank you to Marlene for all the work that you put into this year. So I'm very delighted, excited, also invited to talk to you about the principles of neuroplasticity and contemporary practice in aphasia, and where are we now? Because, you know, we hear neuroplasticity bandied around all the times, you know, in clinic, in the literature, and so I think it's important, really important, that as a profession we start to get to grips of understanding about it, and certainly how it applies to aphasia, because certainly in the aphasia research domain, a lot of the principles are being sort of spruiked and are being applied. So I'm absolutely not going to make any claims that I'm a super duper expert in sort of, you know, neuroplasticity and neurotransmission and all those sorts of neurobiophysiologico, chemico things that happen in the brain. I know a bit about contemporary practice in aphasia. I definitely know where we are now in this room, and it is Wednesday, not Thursday, so thank you for clarifying that. So just a little bit of perspective. Really, when you think about here, 2014, it's a really exciting time to be a speech pathologist. I think it really, really is. And I think my team, stretched as they are, may sort of agree with that as well. Why it's so exciting is that I've been in the profession for a longish time, since last century. And, you know, right from the very start of my career, you know, I was interested in sowing the seeds, you know, and planting, you know, ideas and growing ideas about treatment efficacy, and really about fascinated with the brain and the impact that disordered underlying mechanisms would have on processing and on language and on communication. So, you know, I feel that I'm sort of in a position to talk a little bit about, you know, just how exciting a time we are at now in terms of the evolution of our profession and where we are, and towards the future. And so much has happened, you know, since last century. And back in 1980, when I was a BYT, so a bright young thing, and I would go out to, not a BLT, back in the middle role, I'm now, and I'd go out into clinical practice, and, you know, and I'd always be saying to clinical educators about cases and about treatments, why, you know, and I'd get responses like this, particularly where, you know, evidence was concerned. Why do you do this? Because it works for me. That was a common one. So why? Well, it just works. Okay, why? I don't know. So this is 1980. The patient wants to do it. The doctor said to do it. Well, you know what, there was one study, and in this one study there was one person, and it showed that. So when I started uni, the evidence that we had was really, really scant, 1980. Really, really, really limited and really, really scant. And okay, when you look at that, oh, and the other one, yeah, stop asking and just do it. Okay, when you look at that, certainly when we think of evidence-based practice, yeah, clinician expertise, you know, may come into that, and certainly if you did child audits and things like that, you could probably backtrace things and see that, yeah, it works because it works for that particular person consistently. Now, what is the underpinning theory? What is the underpinning rationale? And how do we progress that? There's also some client values in there, considering what the patient wants to do. There's also some collaboration. The doctor said to do it. I don't know quite collaboration, but anyway. But really, it was just a whole lot of luck. And it was all a bit hocusy-pocusy. So that's what really was the state of play back in 1980. And you know, really, as a clinician, you just go in and wave a magic wand or do something and just hope that it all worked out. And generally it did, okay? Because whilst we didn't have that much evidence in the literature in terms of treatment outcomes, there were at least some nice theories being developed that you could then relate what you were doing back to those theories. Wasn't being pushed a lot in clinical education, but fortunately at the university level it was being pushed. And so we were certainly a generation who was starting to think about that. In 35 years, I mean, so much has happened. And, you know, there's been times when there's been a bit of opposition here and there, you know, between impairment-based aphasia treatment and functional aphasia treatment. But we are sort of, you know, coexisting sort of really happily in the last 10 to 15 years, which is nicely. But also too, we have so much today that we didn't have back then. I mean, look, when I went through in my curriculum, well, these things weren't invented, they didn't exist. There was no such thing as logical processes or pragmatics. Dysphagia, well, yeah, I think I had a 2-hour lecture about thick fluids from the Spastic Centre, as it was called back then. Asperger's didn't exist, and what was cognitive neuropsychology? No, not even a discipline. So, you know, we have so much today, and just in terms of treatment, Lidcombe program and the evidence, LSVT, how much evidence have they got? All those acronyms, and I put them on in for you, Marlene.
Thank you.
And therapeutic tools and things that we can apply. So, you know, we have come such an amazing long way, and I think we have to sort of pay some sort of respect to that, certainly, when thinking about neuroplasticity, because neuroplasticity and how we move forward as a profession is going to be absolutely pivotal, be it in aphasia or in any type of rehabilitation that we're involved in. And that includes some swallowing as well. And thank God for this neuroplasticity, really, because without it, I wouldn't be able to learn about LSVT and Lidcombe program and, you know, pragmatics and all those other things. And also, too, without it, we as human beings, as clinicians, as practitioners, just would not have the capacity to explore any new possibilities, to clinically reason. Because the bottom line is that every thought, every emotion, every sensation, every behaviour that you have acts on your neural system in some way, and we are ever changing as a result of that. You will leave here today a changed person with your brain slightly different to what it was like at this point in time. Okay, even if you sleep, it will still be a little bit different. So what is neuroplasticity? Well, it's the changes in the neural pathways and synapses due to changes that occur in behaviour, in the environment, in neural processes, in thinking, emotions, as well as changes that result from bodily injury. And we've got to remember that too, that injury causes its own unique set of plastic changes as well. The other really important thing, I think, straight, you know, up front to really highlight is the fact that neuroplasticity mediates learning. And, you know, when you look at that triad of what therapy is, what learning is, what the ultimate engram, encoded memory is, then learning is really the neuroplastic side of things. So, you know, learning is the process that we acquire information, behaviours, affective states, impressions, the main activity of the brain, which is consciously sort of modifying to reflect its experiences. So that's learning, neuroplasticity, they're so linked. And so our therapy acts on the system to enable that learning. And then that learning, if sufficient enough, if strong enough, if powerful enough, then gets encoded more, hopefully permanently, into our memory. So, you know, neuroplasticity therapy, and then ultimately memory at the other end of things too, are just inextricably linked. So, you know, we need to sort of be aware of it and just think about how we can capitalise on it even more than we currently are. So a quick little history before jumping into the really key elements. In the beginning, well, actually it wasn't right in the very beginning of time, but at least 400 years ago, certainly 400 years ago, and for the last 400 years, the brain was actually considered to be an immutable sort of object. So that basically there was a critical period in which you could develop certain functions and things, and then after that the brain didn't change. It was a static, stable type of state. And you know, a lot of you people here have not even grown up in the era where that was even a possibility, but I did. As a child of the 60s, okay, the very early 60s, baby boomer, you know, this idea that the brain could not resprout axons or self-modulate once you hit adulthood was still very prevalent. And I recall reading sort of in my bar anatomy book, 1980, the exact phraseology, thinking it was fascinating at the times how rats exhibited neuronal and axonal resprouting following damage, but humans didn't. Oh, there you go. Rats do what humans don't. Okay. We now know that humans do. It's just that we didn't have sophisticated enough technologies to be able to look at sort of what was happening with that. So up until the 1970s, it was very much accepted in neuroscience that the nervous system was essentially fixed throughout adulthood in terms of its brain functions. And it was really quite, unlikely, impossible to develop much after birth. Now, whilst that was sort of purported and proposed, in the 70s, so it was quite dominant when I started working in the 80s. I was always really aware, though, that therapy did kind of work and therapy did kind of make changes, and I was really interested in adult patients. And it was kind of like, well, if adults are learning things, and surely something must be happening to the brain. I mean, it wasn't actually rocket science to make that extrapolation, but it was interesting how, it was still sort of quite a long time until we really, I think, as a profession widely, have taken up these sorts of concepts. And so, thinking about the history of neuroplasticity as well, so, it has been challenged over the years up until that sort of, set point. But really it was, when, people did raise the possibility, it was quickly forgotten or rejected. In 1793, there was an Italian anatomist who did some experiments, and when he did similar training on a pair of different animals, he trained one extensively, not the other, and then dissected them afterwards to see what happened to the cerebellums. The cerebellums of the trained animals were substantially larger. Okay, so, he linked that to the fact that perhaps the brain changed because of its experience with the training. But that was kind of pushed under the carpet a bit. William James, one of the founders of psychology as we know it, proposed in his tome that the brain and its functions were not fixed throughout adulthood. But again, that was kind of pushed under the carpet a little bit as well. Carl Lashley was really quite interesting in 1923 because he did experiments on rhesus monkeys and actually showed some nice changes in their neuronal pathways, in their neuronal maps, and the behaviour that linked to different behaviours over periods of weeks. And he actually was the first one to actually talk about plasticity in that term, so plasticity of neural function, which I think is sort of, quite a pivotal and key thing. So, those rhesus monkeys were sort of, showing some really interesting behaviours. He didn't continue with his experiments, and that was probably a good thing because here are his monkeys before, and this is what might have happened if he continued. So, let's give away the animal experiments a little bit. And then in the 1940s, good old Donald Hebb really sort of, what fires together wires together. That concept, that key concept in Hebbian networks really came to the fore. And this concept of neuroplasticity was reintroduced and started to gain a lot of momentum. And the idea that learning and memory is based on synaptic change started to be explored a lot more. So by the time we get to the 1970s, and Plastic Bertrand, I don't know if anyone remembers him. Anyway, he had a fabulous little perseverative ditty in 1977, ça pla pour moi, 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 ça pla pour moi. That was all the words, that was it, it kept going on like that. But Plastic Bertrand coincided with science, seeing and starting to really appreciate that plasticity was a reality in scientific circles. And actually, at that time as well, all the motor learning group, Schmidt and some of his colleagues, were also coming up with their experiments into motor skills and rehabilitation, had come up with some principles of motor learning, where they were relating that to the brain and functional change as well. So there was quite a lot of interest that was starting to sort of happen and emerge at that time. And really from then, it's grown exponentially. And the concept that new synaptic connections and new pathways could be formed beyond childhood gained momentum as technology gained sophistication and enabled more new and direct windows into the brain and its function alongside behavioural tracking as well. And really, it's irrefutable. Sort of now, look at new word learning, for example. So, you know, unpracticed, practiced after 6 weeks. The brain changes, it reorganises, it consolidates its functions, okay? For us as a profession, whilst, you know, the late 90s and certainly the early noughties were, you know, publishing, we were seeing some really promising studies that were sometimes linking, I guess, you know, what was being seen in behaviours, in treatment studies with possible brain changes. 2007-2008 was a particularly big year and big sort of time of year because these 3 key sort of articles were published in the Journal of Speech, Language and Hearing Research, which really brought to the fore in the speech pathology community's mind just neuroplasticity is here are some principles, here are some ideas or some ways that we may be able to think about translating them into clinical practice. But there are a lot of buts in doing this. And so these 3 papers are really, really seminal, so I urge you to read them because you'll, you know, get a refresher on what I'm talking with you about today, as well as I think start to really understand sort of some of these key concepts. So, you know, 2000, 2008, that's not that long ago, is it? It's really, really not long ago at all. So, you know, given it's only been the last 7 or 8 years, looking what's starting to emerge, we're doing really, really well as a profession. So, the principles of experience-dependent plasticity, which we'll now sort of go through and talk a bit about and unpack, and I'm sure, you know, I hope there'll be some, you know, lively conversations after, and I'm sure that in talking about these, I'll possibly raise more questions than answers, but I've got a couple of good aphasiologists in the audience too, so that's lucky. Okay, and these are the ones really that were espoused by Kleim and Jones. They didn't list them in this order. I've actually listed them in this order for a reason. The reason being that just in my experience, and it's only anecdotal evidence, in my experience and in the research that I've been doing into these areas and into treatment efficacy research, that almost seems to be a bit of a priority hierarchy that seems to be emerging, but also too in terms of the community's interest in these areas as well, it reflects sort of what's being researched a little bit too. So different order to Kleim and Jones, but there's a reason for it, and I've just given you that reason. So, as I said, where we stand at the moment in contemporary practice in aphasia is that neuroplasticity, yes, it's definitely replaced that formerly held position that the brain's a static organ, and obviously it explores the way in which the brain changes throughout life. As a rehabilitation science, as in physio, as in OT, and lots of other sciences, we're really interested in understanding how to use neuroplasticity to its potential in order to maximise our treatment outcomes. And that's really where our research is happening at the moment. There are some, I'm not going to hang around on this slide, but there are some lovely relationships starting to be articulated between and amongst clinical phenotypes, neuroplasticity, potential interventions and assessments. And please note, the interventions are really quite diverse and quite widespread. And most of what we'll be talking about in our comfort zone of speech pathology, of course, is the more cognitive training types of things. But we have to be really open to the future because there are some really interesting things occurring in these other areas, which I reckon in 10 years' time, you know, you'll hopefully reflect back on this workshop and think, oh, when that woman said something about that 10 years ago, it sounded a bit far-fetched, but hey, we use that quite routinely now. It's just become kind of like routine practice. So, you know, a good little diagram for you just to sort of mull and ponder on. And also too, an understanding of aphasia, as I said, has generated some really good lines of research. So we're now going to have a look at some of the current findings. It's not an exhaustive literature review. If someone would like to do a systematic review on any of these areas, go ahead and do it. We'll help you. But obviously too, you know, I really want to sort of entertain and hopefully raise some awareness and also some questions to you just about what we're doing and maybe how we can do it differently in order to enhance our client outcomes, because in the end it's about the client outcomes, isn't it? So, aphasia damages the brain and its circuitry. We know aphasia treatment rewires the brain. And again, you'll see that what is fired is wired. That simple sort of Hebbian premise. A few just upfront realities, I guess you can synthesize from the literature. So neural networks are the essential unit of brain function, and therapy targets that through different types of input. We know neuroplasticity is a reality and is a fundamental principle that underpins the fact that therapy does ultimately affect some sort of change in brain function and also in behaviour. Really important and much work to be done in this area is that the plastic changes can be adaptive or maladaptive. And that's conditions. We can be the drivers of some really lovely adaptive things and some really potent maladaptive things. Which of course then raises the old do no harm in ethics and all sorts of interesting things for the future. This little one I made up. People gain what you train. So if you train a specific function or a specific task and practice it enough, then you can generally shape the person towards that, okay? If you don't train a particular function or task or whatever, unless there's some really fantastic theoretical link where it's subsumed into the function that you are sort of, you know, training vicariously, then, you know, you won't. And also too, obviously, we need to maximise neuroplasticity. We're talking very much about impairment-based stuff here, but, you know, fix the impairment and functional things will also, you know, flow forth. I mean, functional things always need to be addressed in their own right as well. So let's look at those 10 principles and then we'll have some conversations. So the first one is that time matters. So treatment response or treatment responsiveness may vary according to different time windows. So we need to know what those time windows are, okay? And an example maybe of a time window might be when a person starts treatment, okay? So, you know, when they start treatment in relation to their stroke and the natural recovery process that occur from that. Because, you know, we know that plastic changes occur sort of on a continuum, they don't occur all at once. But also too, when, you know, when you're dealing with people with aphasia, you've got this recovery occurring as well. You've got brain-induced, you know, plasticity because of injury. So you've got an injured system and you've got that recovery. So in its recovery, you've got changes just happening themselves. Are there windows there that are going to make people more responsive to different things at different times? Okay, how early do we need to start? So on the basis of that, just looking at what some of the physiological, which are a little bit different to what like Queensland Health definitions are of acute and subacute and chronic, but physiological definitions would say that in the acute phase following onset, that when you do get language recovery, it's really due to that sort of, those rapid physiological changes related to reduction in edema, reduction in the metabolic disturbances, as well as getting that reperfusion of the ischemic penumbra as collateral circulation starts to sort of come into play. So that's just the collateral circulation and everything starting to sort of, you know, come back to right just through natural recovery. In the subacute phase, which, you know, physiologically, people broadly talk about at the 2 weeks to 6 months period, then you would expect natural recovery to be less rapid. Here you get lots of neural reorganisation. Okay, rather than kind of a settling of the system, you start to get some reorganisation happening. You start to get some establishment of some alternative networks, preferably around the sort of site of lesion, it would appear, but also too some synaptic remodelling and a bit of axonal resprouting starts to occur. By 6 months, we know, so without any treatment, recovery just naturally slows consistently. And from this point, you will still get spontaneous recovery for some time, but this is where compensatory mechanisms start to kick in more. So maybe further flung fields of the brain, the other hemisphere, connections there might start to sort of come into play a lot more. I mean, basically the brain wants to perform functions, that's the bottom line. And the brain wants to do the right thing, so it will try and do that however it can, okay? And, you know, in this way, people with aphasia may learn new ways of accessing intact representations through different methods, or may actually start to use alternative pathways to perform the same task. But bear in mind, at this point in time, neural reorganisation generally is a little bit more limited than it is earlier on. So, if therapy promotes neural restructuring, then it should work anytime. But there may be some windows which are particularly effective and directing when lesion-induced reactive plasticity occurs. So thinking about sort of, you know, what the literature says about some of these time windows and where they've done some treatments and things. So the literature shows that studies have shown that recovery in the subacute phases is aided by spontaneous recovery. And some left hemisphere areas which have been rendered dysfunctional actually do show some fairly good recovery. You also get some functional reorganisation complementing this early process. But at later stages, there are two main mechanisms that start to take over. You start getting the recruitment of the residual left hemisphere structures, which is, as I said, often perilesional, and or recruitment of the right hemisphere homologue. So say if Broca's area is damaged in the left hemisphere, then the right hemisphere Broca's starts to become a little bit active. But that's generally a little bit sort of further downstream. Now, what the literature has shown is that therapy effects for language, now we're talking about for language because the motor literature is a little bit different on this, and we'll sort of come to that in a moment. It seems to be greater when therapy is started earlier, when there's more reorganisation happening. And as I said, there's more mixed results with motor movements. A couple of big sort of meta-analyses by Roby showed, you know, these sorts of things in the 90s, that treatment began in the acute phase, and the acute broadly defined, we entered kind of into subacute at 1 to 3 months, had 2 times the effect size of spontaneous recovery. If you initiated treatment in that sort of 3 to 12 month period when there'd been no treatment sort of earlier, you still got some positive effects from treatment over and above spontaneous recovery, but nowhere near as strong or as good as if treatment was initiated earlier. Okay? So, you know, that's been around for a little while actually, but hasn't been sort of, you know, jumped on sort of that much until sort of fairly recently, and you know, this is just one Australian study. This is Erin Gadecki, who used to work in Western Australia, and she's, you know, did a randomised controlled trial, you know, 3 or 4 years ago over in Western Australia, sort of just looking at super duper early treatment. Okay, so basically I said to Erin, you know, so how early? Well, as soon as a patient is able to consent and say I'm able to, that early. So if that's 2 days after the stroke, it's 2 days after the stroke. If that's 2 weeks after the stroke, that's 2 weeks after the stroke. So that early, okay? And she's now she's got a big grant where she's doing a sort of a multi-site sort of trial with this all around Australia. But this was sort of her first smaller trial with 59 people, which is pretty good for a small-scale aphasia study, I can assure you. So what you had was these 59 people sort of, randomised into sort of two groups. And one group had daily treatment, 45 minutes to an hour a day. And the other group just had standard treatment, which for them was just, a small amount once a week treatment, maybe up to 80 minutes. So about 5.5 hours versus 80 minutes. The treatment was very individualised, but it was individualised with every person did get elements of these treatments. They all got some lexical-semantic treatment, so targeting lexical-semantic networks. They all did some semantic feature analysis. They all did a little bit of mapping plus prompted picture description. Now that's what I call sort of like the pre-mapping type of procedure. So there was some sentence-like work that was being done with these clients as well, which is fabulous, and you would always hope that there is. And what they found was significantly better outcomes for the daily group at discharge, as well as 6 months later, these people had much greater recovery trajectories as well. So when they mapped it graphically and mathematically, starting earlier and having that much earlier seemed to improve recovery trajectories generally, okay? So, it was kind of compelling, exciting, all those sorts of things. And certainly, just raises that question, how early do we see our clients? Okay, why, how? Sometimes there's constraints to that and barriers to that. But it's something that we have to start to think about. But as I said, it's a bit of a minefield still because, in the motor literature there's been some devastating things happen, not so much with humans, but with animals. In some of the early studies, when they sort of, gave little rats with simulated lesioned hemiplegias, lots of intensive therapy early on, the stroke actually extended. So they actually got secondary extension from the stroke. So it was like that extra physical activity basically, was maladaptive and toxic to and made the sort of the lesion worse. And there's been some other studies in the physiotherapy and exercise science literature too that have shown that, starting in that first 5 weeks, or another study 3 weeks, didn't really show much positive gain at all. So, okay, that's the big motor movement literature. I guess, a couple of things are raised there. Is animal research the same as human research when we're talking about that extension? And when we're talking about human research, are motor functions the same as cognitive functions related to how taxing a cognitive function is on the neural system? And we don't know the answer to that. Okay, so whilst it's promising, isn't it, that early looks good, there's also that element of caution, isn't there? Okay, that I think we really have to be mindful of as well. And really has to be sort of, studied somehow. I don't know how, but somehow. You could have some difficulty getting it through ethics, I suspect. We'll see. So windows, early is good, but early doesn't mean that, when we're talking about timing, and particularly timing of delivery being important, timing isn't the only ingredient because, an early intervention, because all the seminal cognitive neuropsychological studies back in the early 80s and mid-90s all had people with long-term chronic aphasia who were at least a year post-event, so they were neurologically stable. So there weren't hopefully any or many confounds from natural spontaneous recovery. And providing treatment was specific, providing there was repetition of the same item 2 or 3 times a week, 2 to 3 hours a week, was around about enough over, say, an 8 to 10 week period to produce some really nice outcomes, okay? So in the chronic phase, the picture may be a little bit different, and it would make sense in terms of the brain and how it's organised. But remember with that, the waters are a little bit murky because, as we said, these 2 to 3 times a week in the chronic timing phase, okay, the treatment was also specific. There were other elements of neuroplasticity coming into play. And generally when we're therapying, there are multiple elements coming into play. It's not just, I'm going to work on use it and lose it today. I mean, you're working on a whole host of other things. And it's really understanding the relative contributions of each of these and how they can make the experience of what you're doing in the now richer and more beneficial for the client. That's going to be our challenge moving forward, very much so. But look, there are other time windows as well too we have to consider. During the day, you know, biological circadian rhythms, things like that. And there's been a bit of study in the literature in physiotherapy that's shown better performance at certain times of the day versus other parts of the day. Before sleep, now there's some fantastic sort of literature about memory consolidation and learning. You know, if you study, you know, madly in that sort of, you know, 20, 30-minute window before you go to sleep, then actually your brain will kind of reorganise that and you'll wake up in the morning and remember it all. Voila! Janai remembers me saying something about that to the students.
That worked for me.
Look, you're here. You got a job. But I really think, I think, you know, looking at sort of timings of day and those sorts of windows too in the future are really important. And also too, timing in terms of threshold amounts of a particular, the time you spend on a particular treatment, even in the therapy session, there might be threshold amounts that, you know, so time definitely does matter. And there's a few things that we need to unpack. So, in terms of THMs, I'm trying to be, you know, modern, so they're take-home messages. is that one, Simone, THM? No?
It is now.
Thank you. Let's see how long it takes to get around the world in THM. So early, I think what we can sort of, you know, be cautious about saying, but positive as well, that early treatment might improve later recovery trajectories. Be aware too though that if you do have time delays, as kind of the flip side, if you do have a time delay in starting treatment, that allows for self-taught and other compensatory and maybe ineffective or maladaptive ones to come into play too. All right? And they may interfere with then your training efforts. So, you know, we're being cautious, but we're still saying it's probably early is good because we don't want maladaptive things to come into play that then interference later on. But we still have to be cautious when early because we don't know what the effects are. And we need to dissect, I don't mean brains, but just pull out the other factors like inner treatment, intensity, scheduling, those sorts of things as well, timing during the day, that also come into play as well. So really, you know, moving forward, I think, when are the best windows for what interventions is definitely going to be something that the research will and is starting to look at. 1 down, 9 to go. That was the longest one. Okay, so the second principle, intensity matters. So inducing plasticity, new plasticity, requires sufficient training intensity. So that idea that more treatment sessions per week and greater treatment dosage should enhance neural reorganisation. There is certainly evidence that synaptic responses weaken or can weaken with low intensity stimulation, and that higher intensity does produce more robust responses. However, over-intensity, again, got to be a bit guarded. Over-intensity can create a threshold when no more can be processed. And no more can be processed, then there's no point in continuing. Okay, and in fact, if you go over that, there's even some, you know, research in priming, which isn't, that's a recent article, but this has been known for a while. If you actually go over, you can actually get negative effects on learning and on consolidation. So, you know, yes, intensity is good, but you've got to be guarded. Got to be guarded. And also, what intensity, which time windows, which people, and when, okay? So, it does matter from a neuroplastic point of view, but we need to look at that. In terms of how much is enough, again, now intensity is the one. This is the big one that the speech pathology profession has taken on board, and every man and his dog, which means me as well, has been doing sort of some research in this area. The systematic reviews, which many of you would be aware of, show quite large amounts of treatment per week to get maximum effect. So 8.8 hours a week, a minimum of 5.5 hours per week in our national stroke guidelines. National stroke guidelines are good from a point of view as well, that of course they do have some, nice reviews there, just about sort of what's got sort of, efficacy and what the levels of evidence is. So we're talking about quite a lot of treatment here, sort of generally, aren't we? As many of you would be aware, we're still analysing data from the Queensland Models of Care project that was conducted 3 or 4 years ago. I mean, I basically analyse that data until I retire, which is, a good thing. And what we found with that was that clients who received 1 to 2 hours per week made some language gains. So they didn't make no gains, but clients who received a standard service of 3 to 4 hours per week actually made good language gains. And clients who received intensive service, so 8 to 9 hours, also show good language gains. And actually, when we did the stats, no better than people who had the 3 and 4 hours, but quality of life was better. Much better quality of life, well-being, those things.
Libby, is that mixture of service delivery, or is it just all one-on-one?
Yes. So it's one-on-one, okay. And then the intensive was the addition of computerised therapy or allied health assistant therapy or group therapy. So it was a cost-effective model. So it was like, we're not going to increase the amount of clinician time, we're sort of increasing the amount of time with another platform, okay? And I totally agree, because I'm really interested to know, I mean, what's the minimum amount of clinician face-to-face time does a person need in able to engender change? Okay, that's really what we have to know, isn't it? Because we know that we can do it, but we're sort of looking at that as well with the National Stroke Foundation one. The other thing I'll say about that quality of life thing is that I'm not convinced. I'm not convinced anyway that particular significantly improved quality of life was actually a real effect. I think it could have been a halo effect. Wow, I've had all this extra treatment. Yay, I'm so excited. I'm going to be really happy on my satisfaction questionnaire, and I feel really good because I had all this extra stuff. So 6 months down the track, I wonder if they were maintained. So in the National Stroke Foundation study that we're doing now, we're controlling that a lot more tightly because we have to. But it's interesting, when we get to repetition, there's some interesting stuff that comes into play there, so we'll talk about that. I guess the clinical implications then, if we're talking about sort of intensity, if we're talking about, 3, 4, 5 hours, we don't know the exact dosage. And there are many services maybe that aren't going to be able to offer that. So we need to be creative, but there's also a lot of evidence. There's so many studies now coming out showing the benefits of group treatment, the benefits of computer treatments, the benefits of social treatments, the benefits of all sorts of treatments on actual impairment level as well as participation measures. So there's a whole list of things that we can use, need to explore more further and to get some evidence for, to help us with trying to find out what the right intensity is. But to me, the key question still is how much face-to-face does a therapist need to really do with people? I think that's incredibly important. The other take-home message, I guess, from the intensity though, is to be aware of overstimulation as well and negative effects. And also be aware of over-servicing. I mean, if, that's something that I think, we really have to be incredibly mindful of. That's just a little bit about the current National Stroke Foundation. So with this one, we're just comparing 4 to 5 versus 8 to 9 hours of hybrid treatment. So we've got 2 hours of face-to-face, 1 hour of computer, 1 to 2 hours of group therapy, and then double that dosage. Okay, so that's what we're doing. We've also thrown some neuroimaging on that at the very end, because we haven't analysed the data yet, but just at a first pass, we're getting good outcomes in both. But we're going to be looking at the discourse in a lot more depth, and also the neuroimaging to see whether or not there are some changes there, because there could be some interesting things that are happening that we, don't quite understand yet. Okay, number 3, repetition matters. So inducing plasticity requires repetition, and that can be within sessions and across sessions. Obviously, really important, speaks to all that Hebbian theory, Hebbian networks, and that idea that the more you travel down a neural pathway, the same neural pathway, the more entrenched it becomes. And the more entrenched it is, the easier it is to activate, the more excitable, lower its threshold, and the more favoured it becomes as well. So repetition is really important. But simply engaging a neural circuit in a task mightn't be sufficient to drive plasticity. To actually get a newly acquired and properly learnt, embedded engrammic behaviour, you may actually need more repetition than you actually think on the surface. And so there's, again, more in the rat literature. Again, these rats are sort of, really, as we know, very, very common. There's been some studies to show that rats trained on a skill can show improvement on a behaviour, okay? But when you actually look at what's happening in the brain, the synaptic and whatever reorganisation isn't that great. It's not really where it should be. What it means is that, yeah, we've got behaviour emerging, but it's not fully encoded yet. Unless ultimately it's fully encoded, it's not going to be there to be able to be used almost faultlessly permanently. Does that make sense? So, this is where I'm wondering a bit about this, 3 to 4 hours versus 8 to 9 hours. Yeah, if there might be something in there that we're seeing these behavioural things, but how permanent, how durable, and does that actually relate to differences in what the brain's doing ultimately? So, aphasia treatment studies have shown that good gains have tended to use the same items, presented these multiple times within and across sessions. It can be the same task or different tasks but targeting the same items but in different ways. And actually, motor learning principles, variable practice, random practice too, it kind of draws in some of those things as well too, which is rather nice. But as I said, with a lot of these studies, we need to look at maintenance as well, because it's not just what you get in the now, it's how those effects are maintained down the track. And certainly most of the research that's coming out now, we're seeing sort of tracking of maintenance, 1 month, 2 months, 3 months, 6 months post-treatments to see sort of just what the effects are on the brain and so forth. So I guess clinical implications under repetition is that you don't need thousands or even hundreds of therapy items. Choose, whatever sets you want carefully to fit your client's needs and wants. I mean, they can be functional sets. Repetition, 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 using the same targets in different ways. I mean, it makes documenting progress easier, it makes it easier to train people. But once a person looks like they've got the behaviour, have they really got it at a neural level? We don't know that yet, okay? Maybe they need some more repetition. We don't know. Number 4, specificity matters. So the nature of the training experience obviously dictates the nature and extent of the changes. And learning-induced brain changes will show regional specificity. So training one thing, be it a modality, a task, word type or whatever, will obviously have the greatest effects on the thing that region subserves, that brain region is speaking to. Now, in the animal and human research, there's definitely some evidence to show that performance of just unskilled movements is not sufficient to reproduce the same effects in terms of what happens to the brain with specific training on specific motor skills. And when specific training is undertaken, in the motor literature and everything, you see that specific mapping occurring sort of in the brain, in the neural changes. And certainly we see that in the aphasia literature as well, which is great. So, you know, the neuroimaging shows us that generally semantic treatments activate semantic regions, phonological treatments activate phonological regions. Melodic intonation therapy, you're all thinking, yeah, she's really weird, she's still going on about that after 20 years, 35 years. It can work for some clients, it really can. There's some mixed results on that, but sometimes it seems to activate the right hemisphere, but in other studies, more recent studies, it's showing some left hemisphere activation, but kind of related to prosody and those sorts of areas. So yeah, it does seem to be quite sort of specific, which is nice. So thinking about specificity, we get good outcomes in the studies that have well-defined targets that theoretically link to impairment, which then links to different brain regions. So all those sorts of therapies that, you know, National Stroke Foundation has signed off as being sort of, you know, good and whatever, and specific, you know, certainly seem to be doing their job quite nicely most of the time with our people. But again, it's a skill of the clinician to choose the right areas, the right levels, the right tasks, and all those other things and elements that we're speaking about to make the experience for the client as neuroplastically rich as possible. And look, this is just one of my little meanderings, which I won't sort of, you know, go on about anything more than other to say that, you know, when we use language and when we think about, you know, even just simple processing models, you know, we have different types of stores of information, different types of pathways. We have working memory stores. We have, you know, kind of declarative stores that contain nodes of words or phonemes or something like that. We have connections between them. I mean, the way we do therapy and our specificity in targeting those different things maybe needs to be a bit different. I mean, intuitively, you do it. If you're targeting a buffer system, you draw in more of those sort of length and, you know, holding and enhancing the capacity and the strength of the signal. Whereas if you're doing more sort of nodal reorganisation, you're doing more sort of associative tasks and judgment tasks and things like that. So, does it speak to specificity? Don't know. But certainly that idea, depending on what you're targeting in therapy, you know, the type of process is being targeted, I think you need to be mindful about what you're doing and how you're delivering your therapy too, in terms of teaching on error, timing of delivery, lots of different things. So different approaches and different parameters are actually dictated by these sorts of things. Might leave that one. Now, Salience Matters. So plastic changes are enhanced if the training stands out or is perceived by the trainee to have relevance and value. Okay, if you like it, you're going to do it. Okay, if it's going to help you in some way, it's going to be exciting. If it's interesting to you, you're going to sort of do it more. And retention of knowledge is obviously increased by increasing the commonalities of what's happening in therapy to the person's daily life. Okay, so yeah, transition care, seeing people in the homes, damn good idea. Okay, rather in that little sort of office, almost hermetically sealed, with no sort of other stimuli, where it's really quiet. It's not that replicable in the real world either, is it? No. But anyway, good starting point and really, really required for people, and many people really early on. But maybe we need to move that a little bit more. Okay. Also too, strong emotions. I'm all into, you know, going down, having coffee with clients and things like that. So it's real world. Salience Matters. But it does, seriously. I'm saying that sort of, you know, actually not flippantly. I honestly believe that. So also too, things like, we know that strong emotions, motivation and attention also have neurochemical effects. Now, look, me and neurochemistry, we aren't a good mix, okay? But when we're talking about all this neuroplasticity and everything as well, there's chemical things going on as well all the time too. And where the emotions and motivation and attention are concerned, actually, this is where the chemistry and the biochemical influences really, really come into play and have a really important role in facilitating memory consolidation. Hence, why we've got a few little drugs around that we know can actually sort of assist with, you know, people who've had aphasia. It can seem to promote some, you know, new word acquisition and things like that. So salience, wanting something, looking forward to something is incredibly important. Aren't they incredibly well trained? And it's interesting that really, you know, many studies have not really addressed salience, okay? So, you know, a lot of the treatment studies you see, like for somatic therapy or whatever, it's just, you know, poor client, we don't care about your needs, we just got to work on these boring items. But the client still improves, actually, without the salience. All right, so, you know, we can rewire the brain unsaliently, but salience is really important. And I think particularly if you're getting that transfer then, sort of, you know, back into the environments. And certainly the trend towards having comprehensive aphasia programs, 2-week programs like the LIVE program and some of the ones in North America. And some other recent, I said that, are definitely sort of, you know, promoting salience as a factor, working on personally relevant items and the like. You know, the cumulative outcomes from those studies are that some clients make, you know, some nice progress, some clients make sort of, you know, less than sort of like significant progress, but are still happy with it and get sort of, you know, satisfaction from other means. So the outcomes are really quite variable. But, you know, salience is something that we really need to explore a lot more. And just, you know, simple things, and again, you know, this is a bit grandma, you know, sucking eggs, because I think we all do this already. With communication books and things like that, you know, so photos are their own things, okay? Their own things at home, their own hairbrush from their dressing table, okay? You know, when working with clients, if you're doing semantic, phonological, whatever, choosing items, things, words that are personally relevant or words that the person wants to work on, hopefully within the constraints of the other limits and parameters that you're trying to sort of contain a little, you know, a little bit more to optimise your outcomes. Ask a client what they want. Do they want to learn technology? And just because they say no the first time doesn't mean they won't the next time and whatever, okay? Because variable, different platforms, really, really good. Obviously use and simulate the client's contexts. Okay, so that quiet room, if you're doing auditory comprehension stuff, oh yeah, he's really good at understanding, you know, 3-stage commands now in my room. Well, is that going to work out there in the coffee shop? Okay, so, you know, think about how even simulating that, and you can actually now download apps with party noise and all sorts of different, you know, noises that you can actually play to do masking, things like that. Do therapy out of the clinic room. And again, this is kind of showing to that importance of getting the people out and about and into the world and engaging the inner circle. So the people nearest and dearest to the client, to get them out and about in the world. We want these people to be in the world, not just sitting on the world. We want them in it. And again, you know, as soon as possible. The other thing too about doing all of this, engaging all these salient things, is you're just vicariously recruiting some of these motor learning things related to variable and random practice as well, which is rather nice. So getting people together and engaged and motivated. Use it or lose it. I think that's a fairly obvious one. If you don't use something, the circuit will eventually degrade, and you could even get learned non-use. So you could actually have a function that's okay, or all right, but just needs a bit of oomph. But if you don't use it or you don't give it the oomph, then the person will learn not to use it, and over time it won't actually sort of improve at all, get worse. And lead to further degradation of function. This is something I think, again, ethically, whatever, we have to be really mindful of. Just a guy in my sort of, you know, very first formal research project I ever did, which was my master's research. So he was 27 years post-event. He had limited words in his output, serial naming, brokers, no sentences, no therapy. Years and years and years and years. So when did I start therapy? Years and years and years and years. And years and years and years and years was his sort of recurrent utterance. So he had, you know, really used, you know, hadn't used much and hadn't improved much. 10 weeks of therapy, of targeted treatments, semantic treatment, had markedly, significantly increased context, sentences, fragments, etc. Next stage, of course, was sentence therapy. So use it to improve it. And your client's getting what you train. So, you know, training words leads to more words, we hope. Training sentences leads to more sentences. training more words sometimes leads to better sentences. Include sentences right from the get-go, whatever you do. I don't care what type of aphasia they have. Because, you know, you do blah, 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 sentence mapping, whatever, constrains all that, gives them a template, they can start to map things on, might help their comprehension. And also too, you know, we've got a bit of a preponderance as a profession, we do lots and lots of written tasks, written matching and things like that. Auditory, okay, what they can do in the written, always do it in the auditory. Because if you're not practicing that, that's going to help them, is it? Okay? So your clients will sort of gain what you train. As I said before, how many of us have turned a Broca's into an anomic, a Wernicke's into conduction, and, best one of all, your deep dyslexics into surface dyslexics, because you're specifically targeting certain things in treatment. Maybe, you know, right, you know, best intentions in the world, and I'm not actually saying those changes are actually bad at all. They're probably quite a natural sort of trajectory, and it'd be hard to think how you could, you know, do everything. But it's certainly, you know, some quite clear-cut things that, you know, you are sort of what you train. And I always remember that when I show Mavis, who I have consent for, the video, she's really quite agrammatic, blah, 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 blah. And then she gets to, Huey is 9 and Janet is 6. This beautiful dum, 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 sort of connected sentence. And the students will go, oh my God. And, you know, in her communication book, one of her goals was to be able to produce sentences saying how old her grandchildren were in sentences. So that was like one of those, you know, transference things from that in the context of otherwise quite sort of serial naming and other sorts of things going on. So you can't still gain what you train. That also very much links into number 7, not too many more to go, and they're quicker, they're getting quicker as you go through. Use it to improve it. So the nervous system will change and improve functioning in response to practice. Practice makes perfect, of course, we know that. So you think you want to talk? Well, practice talking, okay? Constraint-induced language therapy, many of you would know about that. There's quite a lot of literature on that now, based on that constraint, forced use and mass practice, or 2 hours a day. You know, has shown some sort of really nice effects. Not for all client groups, but certainly for people with chronic Broca's aphasia, they seem to sort of respond really quite well to this, and quickly as well. So, you know, it's all verbal, nothing else, okay? You can take someone who's got very limited output to someone who's speaking sort of, you know, much better, sort of 3 weeks later after about 30 hours of treatment. You want to talk in sentences? Well, learn and practice templates for sentences, really, really important, and there's evidence for that. You want to monitor your output better, okay? So, you know, use it to improve it. If you want to be better at your sort of output, then the client has to learn to zip, to stop, to think, to whatever, to allow some things to get through. With all these sorts of things though, so when we're talking about use it to improve it, you know, those other principles of repetition, saliency and specificity and whatever too, we're drawing on those when we're really drilling down to our treatment sets and the like. But this is where I guess we've got, you know, probably the most controversial, I think, hotbed of questions. So, you know, what about the areas we don't train? What if I can provide sufficient intensity to create change? I mean, that happens. What about your best intentions to increase functional communication through training compensatory strategies? Writing with the left hand, using gestures. Some people use circumlocutions as a conversational strategy. But are they actually adaptive or maladaptive? Are they blocking? Are they not? Just some food for thought. I'm not answering them. And think about the ethics of it. Okay, so quickly to wake you up, the power of intensity, repetition, specificity, and high internal motivation, and probably even some use it to improve it as well. So I hope it works. And some of you will have seen this. Oh no, where's the sound, Marlene?
It's got your sound thing plugged in.
You know it's in.
It is? Damn!
Just wait.
You've got to see it.
Let's see if we can fix it.
What? Oh.
Yeah, did we?
Yeah.
Okay, it's
Nearly
on.
there.
It's loud.
Ah, okay. Doesn't matter, it's only the executive in here.
It's only the BC.
It's C, yeah, it's C's
Sorry,
video.
Ian.
Why doesn't that work?
I don't know.
That's weird. Is Libby's laptop on mute?
Yeah, we did that before.
I'll just go straight to the original video, will
Looks
I?
like it's on mute.
No, it wasn't on mute, no.
It wasn't on mute?
No, go to the video, yeah.
Oh, I can just... It was such a nice example, had it worked.
It works on your laptop, so.
Worked on the laptop. Slideshow from... blah, 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 blah. Which one am I going from? On current slide. Try again. Oh. Can you... Listen carefully. I love you. I love you. It's like a... Hello.
That's it.
But seriously, think about how they would have been trained, intensity, repetition, yeah? Not that I'm saying we do that to our clients. Make that perfectly clear. Okay, now you're awake. We've got 3 more principles to go and then I wrap up really quickly. Okay, so, transference. So, transference and interference, they're probably, as I said, you know, the new realm. We've always been aware of transference and interference effects, I think, with treatment, but they're the new realm that is starting to be explored. And with techniques and things, a little bit beyond, I think, what we traditionally, classically have thought about doing. So transference is that really to do with generalisation. So altered plasticity in response to one training experience can obviously enhance the acquisition of others, depending on your targets. And you know, those of you who know me, I love generalisation and transference. You know, it's one of, if you can optimise it, then that's, you know, I think really, really good. So, you know, if you've got those connections with your models, your theories, whatever, working on one set of neural connections can obviously create simultaneously and or subsequent plasticity in other neural circuits. And we know just from processing, you've got spreading activation into reality and cascading processes. So we've got connections sort of, you know, far afield within the processing neural system as well for some elements. I guess when we talk about transference, so that you think, well, is that kind of a bit of a contradiction to the specificity idea, you know? And I guess what you've got to remember is that, you know, this transference will happen for some therapies but not others. And, you know, you can be really quite specific about what you want to train. And, you know, if you've got your good models, but you can actually predict what most of the transference or generalisation effects will be anyway. So you know that semantic therapy will generalise quite widely across modalities to other tasks within a certain sort of window level. You'll know that treatment of the underlying form, which is a high-level mapping treatment, highly steeped in syntactic principles, working on more complex forms will actually enhance the acquisition of simpler forms that are actually intrinsic, inherent to those more complex syntactic structures. We know that repetition naming can have some small generalisation effects. We know that verb semantics, working on that, can assist sentences. And again, melodic intonation therapy for another day, maybe next seminar. So I guess, you know, go for transference effects whenever you can, but we need to know, I guess, a bit more about which treatments can piggyback off each other and which ones can sort of go together to sort of, you know, recruit things. So you can basically get your best bang for your buck. So interference effects. So altered plasticity in response to one experience can actually interfere with the acquisition of other behaviours. So there'll be interference. I was trying to be a cool cat, but didn't quite make it. And once, you know, specific neural circuitry is used by one behaviour, it, you know, can't be used again for another, which of course may impair learning. And then overuse of maladaptive strategies as well can also interfere in rehabilitation attempts. And I've just got a sort of a little list there, you know, again, perhaps of where we might be getting some interference, or, you know, there might be some maladaptation potentially going on. So using circumlocution when a simpler word, using that as a strategy when a simpler word is actually available. If you're circumlocuting, you're not going to be able to, you know, that's going to interfere with stopping thinking, getting the real words sort of down, using gestures instead of speaking. Having an overactive system. If you've got one of those more fluent, overactive, jargonistic types of systems with little self-efficacy, that in of itself, the resting states there are going to create massive sort of interference effects. What about when you've got like moderate apraxia of speech, overlaying, moderate aphasia, dual interference? You know, these are really difficult questions to unpack, and, you know, I'm not claiming to know the answers, but it's stuff we've got to think about for the future. Fatigue from overtraining. Order effects. You know how sometimes you're going along quite nicely and you hit something, derails the whole session. That might be that, oh my God, it's too phonologically related, or oh my God, it's too somatically related, or oh, something happens. So that even order effects can actually act and create some interference. And, you know, so the potential for interference is certainly there at that clinical therapeutic level. Moving to the bigger picture of the brain, and I guess recovery. There's also the potential for interference, and some people say from the right hemisphere, okay? So remember when we spoke an hour and 5 minutes ago about the very principle number one, which was to do with time matters, and about recovery and those sorts of things. So we know that good recovery generally in people, good language recovery is supported by left perilesional areas. Some therapies, naming, can often recruit right hemisphere homologs, but actually what they've also found is you can get initial recruiting of that in the right hemisphere, and then you test down the track and it comes back into the left hemisphere, okay? In more severe clients, and severity definitely seems to play a role here, therapy may mobilise either the left perilesional or the right homologs in Wernicke's. But people with significant persistent chronic aphasia definitely demonstrate a lot more right hemisphere overactivity than people with good recovery, especially agrammatic aphasia. And that's now thought to be maladaptive. So in that long-term chronic persistent, it's interesting because stutterers show that too. So adults who stutter show maladaptive right hemisphere overactivation, and kind of in line at about the time they said maladaptive, the stuttering mob came up with the idea that it was probably maladaptive as well. And so it's actually, you know, stopping stuff from getting through. I mean, the brain's trying to work, but it's, yeah, has interference effects. So to summarise, I guess, what's on there is that in long-term chronic aphasia, the right hemisphere is trying to take over the function, but in doing so, it's, you know, not particularly effective, because the most effective pathway is obviously going to be the perilesional, or the one that's closer to home. And how they came to that maladaptive hypothesis was through experiments using transcranial magnetic stimulation. So that's that magnetic stimulation of a low Hertz pulse to the right Broca's area before engaging in naming treatment, and finding that following that stimulation, that naming was kind of released and was enhanced and improved. So it's quite interesting. So transcranial magnetic stimulation, and we're not talking about studies that have been done in Australia, we're talking about some really good studies that have been done overseas, you know, does appear to offer a way of attenuating perhaps some of that right hemisphere maladaptation, which then opens up the left hemisphere to do the job it's kind of wanting to do, which is to, you know, name or produce words or whatever. So this is kind of like a new frontier that we're sort of entering into. And despite recent sort of press, this transcranial magnetic stimulation is not going to go away because there's some really, really good studies that are being done sort of and scrupulously overseas with it. So watch this space on that. The other thing too, related to interference, is this idea that if there is some interference, can we actually release it through the engagement of other cortical structures? So in a very, very sort of recent, like 2014, about to be published, or you know now, article. So Jay Rosenbeck and Bruce Crossan and a lot of that sort of group, who are very sort of, you know, knowledgeable and big sort of on motor as well as sort of language literature, have looked at sort of naming therapies with and without movement of the left hand accompanying it, and have found that when the left hand is involved with the naming activity, then you actually get greater generalisation to untreated items and better longer-term maintenance effects. So yeah, some interesting stuff that's going on, and the idea being that something, because it's activating the sort of the right sort of frontal sort of, you know, motor cortex, okay, that activity, then that's involved in something, so it's maybe releasing in the left hemisphere to do what it's supposed to do, which is name. Does that make sense? It's kind of cool, isn't it? So yeah, oh, and I just thought I'd show you some pretty pictures because I did a functional imaging workshop on the weekend, and I know how to produce ones like that now and analyse them. So I'm very excited about that. But that's actually from that study, the Crossan and the Rosenbeck one, sort of some of the changes, which is yeah, good little read. I'm happy to flip that article to you actually, it's really interesting. So clinical implications of this one is, with any of our treatments that we choose, just think about, does the prescribed task or how we're doing it or the order of it have any potential to block the synaptic activation or neuroplasticity, and is it adaptive or maladaptive? Because remember, you know, it can be adaptive in some, like in the using the left hand to do things. So watch this space as more studies that target specific cortical structures for engagement or disengagement using physiological manipulations or pharmacological, that's the other new frontier, start to emerge. So that's kind of where we're going in this interference, understanding that sort of in our treatments. So obviously we want a greater understanding about what treatments induce, and which changes that we want. And certainly that's, you know, the way that we're going. Finally, age matters. Of course it does. Now we're saying that the brain still changes as you get older, but the older you get, the brain doesn't work quite as well across all those dimensions and all those sorts of functions. But certainly with people who are aging well, aging healthily, and have, you know, a lot of good mental stimulation, you know, that gives very sort of positive prognosis and things for treatment. And another one, which isn't a principle per se, but we all know it really matters, is the size of the lesion and the site of the lesion. That always matters. And that can even have ricochet effects and all sorts of things. Like some of those biggest lesions, for example, watershed lesions, sometimes, you know, the recovery in people is almost protracted or delayed. So, you know, it's not quite the same perhaps as the typical types of patterns that I described earlier. So you just need to be mindful of some of those things. So from 1985, how things have progressed. Things have changed a lot in 35 years. So neuroplasticity is here to stay, I'm afraid. You've all got it. You can't escape it. You've all got it. But research does show us that therapy can work, but the evidence is mounting that we can and may be able to further capitalise on these principles to make therapy work even better with all these things, as well as on the brink of understanding more about transference and interference. Really, our job moving forward is understanding that, tweaking just what for whom. And that's going to give us a lot towards answering that question of our hows. So we do have a long road, there's no doubt about that, but it's still an exciting time to be a speech pathologist. It's still an exciting time. So, thank you. Comment. Statement.